I'm Dr. Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm also an active member of the Institute's Thoracic Oncology program. In advanced non-small cell lung cancer, typically adenocarcinoma patients with EGFR mutations, exon 19 or exon 21 EGFR mutations, the standard of care is osimertinib, and that is based on the results of the FLORA trial, which randomized patients to a first-generation TKI, either erlotinib or gefitinib, versus the third-generation agent osimertinib, and showed an advantage. So osimertinib has risen to be crowned the standard of care in patients with exon 19 or exon 21 EGFR mutations. In the FLORA trial that asked that question, the progression-free survival, which was the primary endpoint, was about 19 months for those patients that were receiving osimertinib, meaning that it doesn't go on forever, the response, and patients will progress. What we also know is that it's important to try to understand why osimertinib, or why patients become resistant to osimertinib. And that's been a very complicated story, and that data is still evolving, but there does not appear to be one dominant resistant mechanism in this particular setting. A couple of things that have come to the front have been EGFR mutations, such as the C797S mutation. There seems to be a higher rate of MET amplification. There are other bypass tracks like RET or ALK or other things, BRAF, that have been described, but there's not one dominant thing. So one of the issues with what to do when osimertinib wears out its welcome is to do a repeat biopsy or plasma testing and see if there is a reason why that you can define that patients are resistant to osimertinib. And that will either create an option of perhaps a clinical trial, but for instance, there are a couple of recent reports to suggest that in these patients with EGFR mutations, resistant to osimertinib, that have say a RET fusion, that we have a couple of RET drugs on the market, selpercatinib and pralsetinib, that have shown, at least anecdotally, to induce responses in these patients with a secondary RET fusion. So you may get a hint from repeat testing about what to do. I would submit that most of the time you don't find an easy answer in retesting, and the standard of care would have to be chemotherapy. In this population, I think they have two choices. Now, most of these clinical trials that involve the use of chemo in immunotherapy excluded patients with EGFR or ALK alterations. For instance, Keynote 189, which looked at carbopemetrexed plus or minus pembrolizumab, excluded patients with EGFR mutations. So you cannot use that clinical trial to make a decision about an EGFR mutant patient. So I think the standard of care, for the most part, includes carboplatin and pemetrexed in these patients, unless the patient is a candidate for bevacizumab, because the one trial that did include EGFR mutation positive patients who had failed a tyrosine kinase inhibitor was Empower 150. And there were about 150 patients on Empower 150. And to give you the short answer on this, there was a huge advantage to patients being treated with carboplatin, paclitaxel, bevacizumab, and atezolizumab compared to carbotax bev alone. So that 4-drug regimen, the hazard ratio for overall survival was approximately 0.6, which was significant. This was following a TKI. So in patients with EGFR mutations who have become resistant to osimertinib, and are eligible to receive bevacizumab and are eligible to receive an immuno-oncologic agent, I think the Empower 150 regimen of carboplatin, paclitaxel, bevacizumab, and atezolizumab is the appropriate choice for those patients. I don't think you can defend any other strategy, as all the other clinical trials looking at chemo IO combinations excluded these patients. And the initial data that we had with IO as monotherapy in the second line setting showed that monotherapy in EGFR mutant patients was no different than docetaxel in terms of its efficacy. So there was no distinguishing characteristic of the IO therapy. The IO therapy was significantly superior to docetaxel in the wild type population, but not in the EGFR mutant population. So IO monotherapy, regardless of the PD-L1 expression level, is not a good idea for these patients.